In the realm of medical conditions, heart failure stands as a formidable adversary, affecting millions of people across the globe. Among its many complexities, one intriguing aspect is the gender disparity in its prevalence, presentation, and outcomes. In this comprehensive video, we delve into the world of heart failure in women, exploring its epidemiology, etiology, presentation, mechanisms, diagnosis, prognosis, and the need for gender-specific research. According to the 2017 American Heart Association, AHA, Heart Disease and Stroke Statistics Update, heart failure is an escalating concern. Its prevalence has surged to affect 6.5 million Americans aged 20 and above, with projections indicating a 46% increase by 2030, impacting over 8 million individuals. Remarkably, heart failure does not discriminate between genders and serves as a leading cause of morbidity and mortality in both men and women. While coronary heart disease tends to strike men and women differently, heart failure takes a more egalitarian approach. By the age of 40, both men and women share an equal lifetime risk of developing heart failure, standing at 1 in 5. However, as the years advance, the scales tip in favor of women. Women at older ages face a greater risk of heart failure compared to men, and this risk escalates significantly beyond age 80. Disparities also extend across genders and races. Incidence rates vary significantly, with Black women exhibiting rates more akin to those of men than white women. Lifetime risk percentages for heart failure differ between genders and races, emphasizing the intricate interplay of demographics and heart health. One intriguing aspect of heart failure is the prevalence of heart failure with preserved ejection fraction, HFpEF, which is more prevalent in women. White females, in particular, have the highest proportion of hospitalized HFpEF cases. Interestingly, age-adjusted hospitalization and readmission rates are similar between women and men, highlighting the pressing need for gender-specific research. In the world of heart failure etiology, certain culprits emerge, especially among postmenopausal women. These include hypertension, valvular heart disease, diabetes, and coronary artery disease. HFpEF, often associated with women, is less likely to be linked to coronary artery disease but is closely tied to hypertension. Heart failure's origins are multifaceted and may include peripartum cardiomyopathy, autoimmune disorders, collagen vascular disorders, cardiotoxicity from chemotherapy, or genetic cardiomyopathies. Stress-induced cardiomyopathy, which predominantly affects postmenopausal women, offers a glimmer of hope as it's often reversible with better long-term outcomes. One significant observation is that women tend to develop heart failure at an older age compared to men. HFpEF, more prevalent in women, leads to heightened symptoms and equally poor outcomes when compared to men with low left ventricular ejection fraction. While the overall signs and symptoms of heart failure appear similar between genders, nuanced differences arise. Women report higher frequencies of dyspnea on exertion, exercise difficulties, and edema. Quality of life ratings tend to favor men in intermediate activities of daily living and social activity, even when controlling for factors like age and ejection fraction. Depression is also more prevalent in women with heart failure. Diagnostic criteria remain largely gender-neutral. However, it's essential to recognize that cardiac structure's dimensions should be indexed to body surface area for women and men, considering differences in normal values based on gender, age, and body surface area. One possible explanation for the gender-based differences in heart failure symptoms lies in diastolic dysfunction. Women often have lower left ventricular end diastolic volumes compared to men at similar pressures, suggesting a link to diastolic dysfunction. This condition is exacerbated by factors like hypertension and aging. Physiological differences between women and men extend to aspects like left ventricular mass, contractility, coronary vessel size, and catecholamine-mediated vasoconstriction. These variations contribute to divergent disease courses and outcomes. Survival rates for heart failure have shown improvement over the years, but the disease remains a formidable foe. Approximately 50% of individuals diagnosed with heart failure succumb within 5 years. Both men and women experience reduced survival with heart failure. Despite overall progress, gender disparities persist. Women generally survive longer than men, particularly when the etiology is unrelated to ischemia. However, disparities arise when HF develops from coronary artery disease, possibly due to differences in treatment approaches. Ethnic and racial disparities in heart failure outcomes are noteworthy. Death rates for non-Hispanic Black women, while lower than those for men, remain higher than other ethnic groups. These disparities underscore the importance of considering demographic factors in heart failure research and care. Despite the unique pathophysiology and etiology of heart failure in women, clinical trials have consistently underrepresented females. Women account for only 20% to 25% of subjects in major heart failure studies. This glaring gender gap in research hampers our understanding of the condition's nuances. To address the disparities and unanswered questions, further studies are imperative. Research should delve into the diverse mechanisms, causes, and targeted therapies specifically tailored for heart failure in women. In the intricate web of heart failure, gender plays a significant role in its prevalence, presentation, and outcomes. Women face unique challenges in their heart failure journey, and a deeper understanding of these differences is essential for delivering optimal care. Heart failure remains a formidable foe, but through comprehensive research and gender-specific approaches, we can pave the way to